Welcome to Reboot with Dr. Arasi Maran. It gives me great pleasure to have Dr. Mohan Sundaram, who's a long lasting friend of mine, to join me today. I'm also joined by another special guest, my daughter, Rhea Maran Pulat, and she's going to start us off with the first question. But before that, Dr. Uma, can you please introduce yourself and tell us all about
Thank
you?
you, RC. Glad that we're doing this together. Again, my name is Mohan Sundaram. Did my medical school in India along with RC in Annamala University. Came to the US and did my master's in epidemiology, clinical epidemiology, and then did my internal medicine residency and a pulmonary critical care fellowship right here at Stanford, and then joined Kaiser Permanente Medical Group. I've been with Kaiser for almost 15 years now. I am a full-time pulmonary and critical care physician. I'm a chief of pulmonary division here. My expertise is predominantly interstitial lung disease, which is about lung inflammation, scarring, pulmonary nodules, diagnosis of lung cancer. So I do plenty of diagnostic interventional bronchoscopies, and it's my passion to do all the procedures and get into therapeutic bronchoscopies also. So here we are.
Uma, thanks so much for that. As I've said before, Rhea is going to ask the first question. So, Rhea, go for it.
Yes, Rhea, go for it.
Umata, is snoring bad for you, or is it just something obnoxious that people do in their sleep?
Very good question, Rhea. So can I explain to you what snoring is? Why do people snore, right? So why does that noise come? So, when you inhale, when you take in the air, right, as the air flows through your nose into this big windpipe, right, airway, when you have really thick neck, or if there is anything that's obstructing that passage, all the tissue there is going to make that sound. Okay, that's called snoring. Snoring is annoying, of course, but it's also bad for you. Okay, because that flow that goes into your airway is completely obstructed. It's not going properly. So what happens? You get low oxygen, and oxygen is we need oxygen, right, for your heart, for your lungs, for everything, for your brain, for good skin. So we need oxygen, right? So all that is going to be a problem when you snore, when you have low oxygen. So it's not good for you.
Okay. Thank you so much for joining us, Rhea. Bye.
Hi, Rhea. Good seeing you.
You too.
No, go. Thank you, Ma. Thank you for indulging my daughter. So it's a great question to start off with. But is all snoring bad? Is if you snore, is it pathological right away, and you have to seek treatment right
Yes,
away?
good question, RC. So snoring is bad. Now there can be various severity of snoring, right? And also the causes of snoring. People snore when you have nasal congestion, right? When you have bad allergies, when you put your head back, when you put your neck back, you can snore because of that. Is that bad for you? Not necessarily, right? So you just clear your allergies, clear your nasal congestion, the snoring is going to get better. People snore when they drink too much alcohol, right? Is that kind of snoring bad for you? Not necessarily. Drinking too much alcohol is bad, but not necessarily the snoring as a result of that. But people snore because they have pretty bad sleep apnea. We can talk about what sleep apnea is, but in just a second. But the snoring that occurs because of sleep apnea can be bad for you, and that needs to be treated.
So what do you do? Most of the time people think of snoring as a normal physiologic, it's just natural to snore, and therefore, nothing needs to be done about it. I don't see every person who snores around the world going and seeing a ear, nose, and throat specialist or a pulmonologist. So what is your take on that?
Snoring when associated. So number one is how frequently are you snoring? Are you snoring every night, several times a night when you're sleeping? And snoring,
stopping the breathing or snoring continuously? What do you mean?
Snoring. So snoring cannot be continuously throughout the night, right? So it can be intermittent snoring through the night, and especially when it's associated with increased daytime somnolence. What does that mean? When you're just tired the next day. When you're waking up with gasping for air in the middle of the night, right? So you're just like sleeping, and then you're awake all of a sudden because you're not getting enough air. So it's that kind of snoring associated with these symptoms can be bad for you and could be suggestive of obstructive sleep apnea.
So when do you? Most of the times, you're sleeping, you don't realize whether it's continuous or intermittent, and what you do in the night, you don't even remember in the morning. Like, how do you know? Oh, this is a problem. I need to go get help.
So, like you said, we don't know if we're snoring or not, right? So when a patient comes to me to see me in clinic, when they're like, most of the symptoms I see, like, oh, Dr. Uma, I'm so tired. What do I do? And then when they are with a partner, I'll be like, oh, is this your bed partner, right? Is this partner? Can I ask that bed partner the question? So I usually ask the partner, hey, what is he or she doing? Is he, let's say is he snoring, several times a night? Is that snoring waking you up? Is that snoring waking him up from sleep, right? So those are the questions I would typically ask. And then I would move to the patient and say, like, hey, are you falling asleep easily? Let's say you're reading a book or watching TV. Are you falling asleep right away? Are you waking up in the night, with like dry mouth, headache? Are you waking up just feeling like not had a good night's sleep at all? So those are the symptoms that can go along with when it makes me think about obstructive sleep apnea.
So, would a pulmonologist be the first point of interaction, or primary care, or ear, nose, and throat? Who should be the next step? Let's say
Yeah.
I have snoring, which is bothersome. Who should I go see first?
Primary care physician. I mean, they are the gateway to our body, right? I mean,
Yes.
without primary care physicians, specialists cannot exist. So they are the gateway. So a patient will directly go to their doctor and say, hey, doctor, I just, why am I so tired? Okay, that's what they're going to do. And, as a primary care physician, as they go through their routine workflow of like, could this be anemia? Could this be what else, right? So as they go through that, they know, primary care physicians know, and with the body habitus, which we can go into in just a second, they'll ask these questions about, hey, are you snoring? Or if there's a partner, hey, is he or she snoring? Then that's how they start the questions. And usually there is a questionnaire that we have in our sleep clinic that includes, the snoring, daytime somnolence, morning headache, how many times they're waking up, gasping for air. So they fill their own questionnaire, and then we come up with the Epworth Sleepiness Scale, it's called. And based on the score of the scale, we think about what the next step is. Usually it's an apnea test.
So, how dangerous is it? Is it something very benign, or is it like, oh, if your partner is snoring, you need to take action? Where does it fall in the
Yeah, I
spectrum?
think, I think it depends on other comorbid risk factors too. For example, let's say a patient has a heart disease and comes with snoring, right? The first thing I really want to know is if that patient has obstructive sleep apnea. Like I mentioned before, not every snoring is because of obstructive sleep apnea. It could be just allergies, congestion, whatever, right? But if there is, but I really want to make sure that person does not have obstructive sleep apnea, because obstructive sleep apnea is absolutely important to be treated, because we know that increases your risk of coronary artery disease. It increases your risk of cardiac arrhythmias. It increases your risk of ischemic stroke and kidney failure. So
Fibrillation, pulmonary hypertension.
and hypertension, systemic hypertension, as well as pulmonary hypertension. We know that increases your risk of various dangerous diseases, right? That
I'm
needs to
just
be.
going to take the non-medical terms away. So
Yeah.
basically, if you have obstructive sleep apnea, you're at high risk for irregular heartbeat, you're at high risk for heart attacks, high risk for strokes, high risk for blood pressure, overall, and also inside your lungs. So it pretty much covers head to toe, I would say.
So that's why identifying those patients who have obstructive sleep apnea is absolutely important, so that they can be well treated.
So we talked about the first step, going to the primary care physician. They do the Epworth sleepiness scale. What's the next step?
So once they do the scale, they say, oh, this patient has, checked these questions as yes for most of these questions. The next step is to see, hey, what kind of, should this patient go to a sleep physician? So in our world of pulmonary and critical care, we have a separate board certified sleep physician, or pulmonologists can do this too. General pulmonologists can do that too. So we end up seeing these patients in our sleep clinic to do a sleep study. I've seen in the past, all these patients have to get a sleep study done, meaning to see if they have obstructive sleep apnea. they have to spend the night in the hospital in a sleep lab. We would hook up a monitor over their head, their chest, and we would make them sleep in a very random bed and check for like sleep apnea or look for what the score is, right? But advanced medicine these days, we do something called a home apnea test, home sleep apnea test. It looks like a little watch, it really looks like this watch that they can wear that checks their pulse, their oxygen level in the blood, okay, and how many times their breathing stops per hour, or how low their breathing goes down. So that's called apnea and hypopnea, okay? How many times they stop breathing and how many times they breathe less, okay? So that's what we check every hour, and we finalize a score. And it also checks what their oxygen level does in the night. We all know, like, our oxygen level generally goes low by about 3 to 4%. That's a normal range without, a very healthy person can have. But in these people, they can go to a dangerous level. And that's what we're trying to finalize with this watch. It's called WatchPad, which is commonly used in the US. It's a watch that we send the patient and say, like, hey, sleep well in your own bed. Okay,
Yes.
wear it overnight, 10 p.m. to 6 a.m., whatever. At least 4 hours of sleep, do it, and then drop it off the next day, and then we'll see what that shows. And that's how we diagnose sleep apnea.
I think you can't make it easier than that if it's just wearing a watch.
Yeah.
That's pretty good. So, and what does if the test results show obstructive sleep apnea? Are there levels,
Yeah.
severity levels?
So obstructive sleep apnea comes with, we generally classify as mild, moderate, severe, like in every single thing in medicine, right? So I think, just for a general purpose, it's important to know that, because a lot of studies have shown that someone with a moderate to severe degree of obstructive sleep apnea, and I keep saying obstructive, RC, because there are different kinds of sleep apnea too. There is something called a central sleep apnea, and there is different
Yes.
sleep-related disorders.
We are focusing on OSA.
We'll focus just on obstructive sleep apnea, okay, for the purpose of what we're talking about. So, if it's moderate to severe sleep apnea, then we know these patients are at high risk of everything that we talked about before. So these are the patients we really need to focus on and treat with specific treatment management we can talk about. But if it's mild, meaning mild is usually classified as if they have decreased, breathing rate less than 5 times or less, then we talk about, hey, this is what you have. You could use that machine that we'll talk about in a second for treatment, or think about adjusting and modifying your lifestyle, right?
Okay.
Lifestyle changes can be sleeping on your side, making sure you don't have any nasal congestion, exercise, watch what you're eating.
So let's focus a little bit more on the mild process, and before we jump on to the moderate and severe. So what are the risk factors for sleep apnea or obstructive sleep apnea?
So the risk factors, one of the biggest risk factors for obstructive sleep apnea is obesity. Okay. How do the way we define obesity in this country generally, I think, is very, I think there's a lot of controversy around it, as you probably know, right? But obesity is one of the major risk factors for sleep apnea. But you see sleep apnea in like very thin people too. Why is that? Because they may have a very short neck, okay? If their neck diameter is very short, right? So if the neck length is very short, if the neck diameter is too thick, if they have redundant tissue, thick, short neck, okay? If they have a lot of like just redundant tissue in the back of their, nasal passage, those are all the risk factors. And smoking is a risk factor for mild sleep apnea also.
Okay. All right. So where you kind of mentioned before, you can't do anything about the length of your neck or the thickness of your neck. I mean, it seems like an unmodifiable risk factor. So the only modifiable seems to be the weight of an individual. So if extremely thin people have snoring, are they destined to wear the CPAP machine or anything of that sort?
I mean, even though we do recommend, hey, you have mild sleep apnea, can this progress into moderate or severe as you get older, or change, you may have change in your lifestyle? You could wear it, but most people don't, Darcy, honestly, right? It's you can think of a contraption that you're wearing overnight. It's hard, especially when you don't have that bad of a disease, right? So we usually recommend just lifestyle modification, sleep on your side. Okay, most times, you will have that obstruction when you're sleeping on your back, supine on your back, right? So we recommend sleep on your side, get used to sleep on your side, have a little wedge in the back, okay, so that you're slightly elevated. So like, you can have a sleep modification, sleep regimen modification.
I've seen a lot of ads, of these oral devices, devices which pushes your tongue out, it pushes your lower part of it. Are they effective?
Unfortunately, no. Okay, so the treatment, the proven treatment, we know the highly efficacious treatment for sleep apnea, especially moderate to severe sleep apnea, is CPAP machine. Okay, which is the continuous positive airway pressure. Meaning, what does it do? It's a little contraption that we wear over a nose or the whole nose and mouth. It pushes air. Okay, it's basically just pushes air into the
Right.
passage, right? So that it opens up that redundant tissue, opens up all the tissue, gives gives space for oxygen to go in, right, and air to go in. So that is the proven treatment for moderate to severe sleep apnea.
So even for mild sleep apnea, those oral devices don't wear because that's what they are selling them for.
Yes,
For
yes,
mild
exactly.
sleep apnea.
And those things are still very controversial. I mean, is it worth spending that much money and getting a device that is not well proven for like mild sleep apnea? I mean, that's up to the patient, of course, but there's really not good data on these other devices at all.
So one more, you're going to laugh at me when I even ask you that. I have seen ads for tape, mouth tape,
Yeah.
where they just shut I mean, it looks ridiculous. The name is even more ridiculous that anyone will be actually, will pay good money to. It's called the hostage tape or whatever. I'm not even, what is that? Is there any science behind shutting your mouth with the tape, like a duct tape, and saying your sleep apnea is going to get better?
No, RC. I hate to say it, that's not going to work, okay? But, interestingly, excuse me, interestingly, for people who use the CPAP machine, right? So when they just put that mask over the nose, if you're a mouth breather, you can think of how air can escape, right? So we'll do like a chin strap so that your mouth is shut, okay? But
Okay.
then you have a mask over your nose. So that we use as a chin strap, but only in conjunction with the CPAP machine, but
But
not
nothing
just
to tape
but
your
not
mouth.
just to tape your mouth. No, I would
Okay.
stay away from it. Do not try it.
Yes, yes. Please do not buy those devices. It's so
Yeah.
ridiculous. So, how about we talked about weight loss. How about exercise? Because thin people, they don't have a whole bunch of weight to lose, but does exercise improve the tone of the muscles and things like that? Does that help?
We know exercise improves several sleep related disorders, okay, not just sleep apnea. Majority of the Americans suffer from insomnia, unfortunately, especially in this like world of social media, and like we're sleeping with our phone, we're keeping the phone on to like 11, 12, whatever. Insomnia is the most common sleep related disorder that we see for sure. So for those patients, we highly recommend exercise, right? Not just exercising right before you go to bed, like exercise, evening, so that you have your endorphin, you calm down after that, you have a reduction in your heart rate after exercise, and that will ease you into your sleep. That's one of the treatments we know for like insomnia. But you ask a really good question, that does a thin person need to exercise? Yeah, I would still say yes, not necessarily with the intention of losing weight, right? But to really to understand and equilibrate your sleep cycle, right? You want to have a good circadian rhythm, so the sleep cycle you want to moderate for that reason.
So, I want to segue. I'm deviating a little bit from sleep apnea, but I'm going to circle back to it.
Yeah.
I want to talk about sleep hygiene here. Can you tell me, 5 things which we need to know about sleep hygiene?
God, I mean, I'm saying this and I don't practice half of this. Okay, I will I will say that right away.
Well, we're all trying to do better.
We're all trying to do our best, right? Number one is for sure, I think, putting the phone away, right? Keep the phone elsewhere. When you're in bed is for sleeping, but not to sit and scroll through your phone. The phone is out the room. That's number one for sure. I think there's something to say about, going to bed early and waking up early, right? So that's definitely, there is good data that, your hormones really regulate yourself by like, 8 to 9 p.m., right? By 9 p.m. bedtime is there's good data on that. So that definitely works. and avoiding any caffeinated products, beyond like 3 p.m., right? Because beyond that, you're going to you still cannot regulate the heart rate. You're still pretty high with that, right? And exercise is great for you, but earlier on in the evening, not right before you go to bed, you hit the gym. So definitely not. And obviously, healthy eating definitely makes a sense. Avoid smoking, eating, alcohol. All that is helpful for a good sleep hygiene.
Okay, so now let's revert back to moderate to severe sleep apnea. You
Yeah.
mentioned a little bit about the CPAP machine. It's a very inconvenient machine. I mean, I've seen the mask, I've seen the pillows, I've seen patients use. The compliance rate is really, really poor. How do you encourage people that it's worth their time to put up with that appliance?
I see that's a very good question because that's something that we really struggle with, right? And what I've realized in practicing medicine is if you understand why we're doing what we're doing as a patient, if someone explains to me, hey, this is what we recommend that you do. It's our body, it's your body, but it's your as a team that we're working together. I do not perform miracles, right? So we do it together. So let's be proactive and do this. As long as I explain to the patient what we're doing, you'll be surprised to know that patients actually do well. What we know, the data is patients with severe sleep apnea. How do we define severe is, remember I talked about the number of times you stop breathing in the night, right? These guys stop breathing more than 30 times per hour. So it's really significant, okay? And their oxygen level can go low as 70%, 67%. So it's ridiculously low. So they are at super high risk of all the diseases we talk about. So when I explain it to them, and when they start using the CPAP machine, RC, they have a dramatic improvement in the quality of life. They love it. They'll be like, Dr. Uma, I cannot sleep without my CPAP machine. This has been the most life-changing device in my life. I mean, there's very few things I hear about that in pulmonary medicine, but
Yes,
that's
yes.
something, severe sleep apnea patients will absolutely testify for, right? So no question about that. But it's the moderate guys who are really troublesome because it's not too bad, but it's bad enough that something needs to be done, right? So what I tell these patients is like, hey, try using it like 2 hours at a time. Sometimes just wear it when you're watching TV, so that you can get used to the device, right? But wear it 2 hours every night. Maybe increase it to 4 hours. Nobody gets used to it, right away. Give yourself a good 2 months to get used to it. So it's a you need to bring them back. I have amazing respiratory therapists who talk about compliance, who talk about the benefit of CPAP. It's a constant reassurance that it's going to work, it's going to make a difference.
So, I want to talk about this thing. I have seen patients who have a diagnosis of obstructive sleep apnea. They are wearing the CPAP machine. They are compliant with it, but they don't see their lung doctors. They haven't seen the lung doctors for 2 years or 3 years. I'm like, how do you know you're getting the adequate amount of pressure? So how frequent is the follow-up after this disease?
That really depends on facility to facility, okay? And especially what in the US, what the insurance is. For example, Medicare patients, right? Patients who are more than 65 years who have Medicare as their insurance, we have to follow them within the first 30 to 90 days. There's a new rule that states that we need to make sure. Most of these CPAP machines come from a certain company. At least in California, there's a company called Apnea that sells these CPAP machines. So we download these data, RC, through iCloud. Okay, so our respiratory therapists they don't have to bring their machine back for us to look at the data. We have an iCloud data that just transfers the data into our our software so that we know what's going on, right? So, and then, these patients can remain stable without any problem as long as their pressures are adjusted. Usually we don't just set like one pressure through the CPAP. We give a titratable pressure so that it adjusts based on their need for that night, right? But, if patients start having symptoms again, saying that, hey, Dr. Uma, this is not, why am I feeling tired again? That's when I know, okay, something has changed in their life. Bring it back. We got to do a repeat study.
So, I'm hopeful that this podcast is reaching people beyond the US, where
Yeah.
this the cloud data collection and respiratory therapist opportunities may not be available.
Yeah.
So, for those people who don't have such things, how frequently should they be talking to their doctors about their CPAP machine?
I think it's, like I said before, right? It's the compliance of this machine is stuff, right? It's
Mm-hmm.
up to medical team, physicians, respiratory therapists, nurses, whoever, medical team, their partner, their family member, right? To make sure that they're compliant with it. How do we increase compliance? Frequent reassurance, reinstatement. Like this is, hey, please try this. This is good for you, right? 30 days, next 3 months, 6 months, 1 year. It takes a simple telephone. You don't even need to see them back in clinic, a telephone visit, right? In India, I understand, like for example, right, if it's beyond US, right? So it's I think it's very helpful when we see patients in clinic and say like, hey, can you give it a try? Just try for like few hours every night. So frequently seeing them at least for the first year, I think it's extremely helpful. Once they're compliant, once they see the difference, you don't have to worry about it.
So, shifting gears from non-invasive therapies like CPAP, are there any surgical procedures you can one and done and you're cure of obstructive sleep apnea?
I see you're going into a very controversial topic, okay? In our world of sleep medicine, yes. I mean, you know, patients are hearing it from their friends. Hey, I had a surgery. I'm not going to wear this like CPAP machine. I had this surgery. What do they do in that surgery? So remember, one of the risk factors was like short neck, thick neck, right? So what they do is there's a surgery where they advance their mandible, which is this lower jawbone. They advance it surgically, okay,
Oh,
so
wow.
that you're not tightly shut, right? So you have more flow in the back. They
Mhm.
remove the uvula right at the back, okay, so that the redundant tissue doesn't, obstruct the airway. So those are all the surgeries available. Now, do they really work or not? There is really not good evidence that it 100% cures sleep apnea. To this date, okay, CPAP is the gold standard treatment for obstructive sleep apnea, period. Okay, all the additive, the extra devices you can try, because if you just cannot tolerate CPAP, okay, something is better than nothing, okay, so you can try different things. There are a variety of other things like hypoglossal nerve stimulation. You might have heard
Yes, the
about that.
Inspire
Right,
pacemaker
so that
thing.
stimulates a nerve so that
Yeah.
so that you're breathing well, so that but it has its own side effects. So we know there's really not good evidence that it 100% cures obstructive sleep apnea.
So, we talked about weight gain and obesity as a major risk factor. So, I know this is a funny question, but I'm going to ask it anyway. Is there a percentage of weight loss which shifts you from, moderate to severe or severe to moderate to mild? Like, let's say I'm 300 pounds,
Yeah.
and if I come to 250, I mean, like, is there a 10% weight loss? Does that help in sleep apnea? Or you want 25% weight loss? Is there a number like that which can be effective for OSA?
So I think, again, it depends on, I could have like 100 pounds to lose, right? But if I have a short neck, that's not going to help at all, right?
Hmm.
So I can still lose that 100 pounds, but I still have that anatomical problem, causing that obstruction. So I will still need that CPAP machine.
Patient has a normal neck, not a, it's only related to the
Yeah.
weight. So I'm talking about that specific patient.
I mean, the data shows about like 10 to 20% weight loss is great to bring down the severity of the sleep apnea. So
Okay.
let's say like from severe to moderate, right?
Okay.
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 But for a very obese, morbidly obese patient, that's a different ballgame.
Oh, yeah, that is absolutely true. Uma, thank you so much. We dealt so much about obstructive sleep apnea, which is so common. Like every other person we know snores, and we all think this is a natural part of aging and growing up. And thanks for telling us what all we should be doing, when should we be following up with our doctors. I truly appreciate the time and the detail with which we have gone to.
Thanks, Arsi.
Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.